Good morning, everybody. All right. Wow, that's really loud. Okay. I'm going to introduce Dr. Brigham Willis, longtime educator, scholar, and leader in academic medicine. Brig earned his medical degree from University of California, San Francisco School of Medicine, and then completed his residency at Children's Hospital and Research Center in Oakland. Dr. Willis finished his training in a fellowship in a pediatric critical care medicine fellowship at Children's Hospital Los Angeles, later serving as the Associate Fellowship Director for Pediatric Critical Care Medicine at the University of Texas Southwestern. Prior to his recent move to Tyler, Dr. Willis served as a professor of pediatrics and the Senior Associate Dean of Medicine Education at the University of California, Riverside School of Medicine. And Carolyn Morales serves as the Associate Dean for Belonging and Community Engagement and Assistant Professor of Medical Education in the School of Medicine at UT Tyler. Dr. Morales also has 20 plus years of leadership experience in operationalizing,
Yes.
diversity visions into strategic plans and solutions within higher education, nonprofit, and business sectors. Carolyn has a PhD in leadership and change from Antioch University. All right, I'm going to give this to them.
Wonderful. Okay. Good morning, everyone. Pleasure to be here. We want to make this as informal as possible. We really want it to be a dialogue and a conversation because we're going to give you a lot of information. But at the end of the day, our goal is for it to be useful and practical and something you can take back and potentially develop further in terms of your own strategies that you're evolving within your own respective organizations. So that said, our presentation today really is Community Engagement and Health Equity, a new social contract for academic medicine. Sounds very lofty, right? But we're going to really kind of deconstruct what that means as we evolve the conversation and the presentation today. So what do we want to help you learn? So our objectives were really to be kind of utilizing a systems-based approach to really looking at how you create and develop and roll out a community advisory board, and really linking that board to your engagement goals and health equity outcomes. They have to be connected. We also are looking at giving you some wisdom and some insight about how you can utilize a CAB, a community advisory board, to create opportunities for you to kind of share information across constituent groups, to create dialogue, and really importantly, to construct feedback loops that really kind of level set your understanding of where the health equity gaps lie within your respective regions that you work with. We're also wanting to apply a new model I created called the Intersectional Health Equity Model that I want to present to you today. And it really is related to our evolving work at the School of Medicine. And it looks at how you can determine how social identity and social determinants of health impact health outcomes. It looks at the relationships between the two. We'll learn how to co-construct community-aligned transformational service projects, programs, and research priorities. We have one that's evolving that we want to share with you. And then really consider how these partnerships between schools of medicine and community stakeholders represent the new social contract in medicine. So I'm going to hand it over to Dean Willis, and he's going to kind of work through the next couple of sections. Wonderful. There's that.
Thank you, Carolyn. Appreciate it. Hi, everybody. It's really an honor for me to be here again. I'm Brigham Willis. I'm the founding dean of our new medical school in Tyler, Texas. We're very excited and proud to be starting that effort in our community of East Texas. How many people have ever been to Tyler? You've been to Tyler? All right. It's incredibly beautiful. People don't even know. It's the prettiest part of Texas, I'll say. But this conference in particular is really excited to come to because what you guys are doing in your organizations on the ground, actually trying to affect change in your communities, is exactly what the med school is trying to do, right? The reason our med school even exists is that we have huge disparities in health equity and health outcomes and sort of across the board needs in healthcare workforce development in the communities of East Texas. We sort of have a 42 county catchment area that we're trying to deal with. So it's a big job, an area bigger than West Virginia. And so when we put the medical school together, and we're the 156th member of the AAMC, so one of the newest medical schools. But we wanted to lead the way in creating a new paradigm for how medical schools interact with their communities and serve their communities. Since this is such a kind of nice, intimate group, I would love to know where everyone is from. So do you mind if I do quick, like, I would love to know, sort of name, where you're from, and what, if you're engaged with a med school at all, that would be interesting to know. Where you, yeah. Okay. And do you work with a med school at all? Okay. Fantastic. One of our biggest foci. Yeah. Fantastic. Okay. All right. Nice. Okay. I spent many years in Children's Hospital, Phoenix Children's and Rady's, and perfect. Wonderful. Okay. Nice.
And I am an associate manager at transformational operation.
Okay. Good. Do you say Lisette? It's my wife's name. That's a great name. Fantastic.
Okay, so we're very close proximity. We're housed in Terrell and very offices. We're actually working with UT Tyler trying to put
Wonderful.
residents in a Mount Pleasant location.
That is fantastic. Yes, Dr. Brandon Riley, yeah, our program director. That's wonderful. Thank you.
And as far as I know, I mean, my program doesn't work with it.
Okay. Thank you. Hi.
I work with
Medical school.
I work with the medical officer.
Okay. Yeah, fantastic. And we had 2 new arrivals. We're saying who we are and where we're from, and if you have a medical school connection already.
So resources, my background was in social services prior to this, so yeah.
Fantastic. Thank you.
Good morning. My name is Erica Dykes, and I am a social worker by background and director of comprehensive care management. Organization, and yeah, we work for numerous.
Fantastic. So this is so great. I mean, hearing about the behavioral health focus services to the community on so many different levels and sort of variable levels of medical school engagement. And so that was one of the things that I wanted to make different when we set up this school, is to have the medical school be engaged with as many community organizations in a very fundamental way, because you guys are the ones that are actually affecting change. I've been through multiple startup medical schools, 4 in a deep way, and they all say something about we're here for the community, but often not a lot of actual action happens, right? There's a lot of research that happens. They kind of go to the community and do research, and then they kind of go back to. So I wanted to make sure We didn't do that when we were setting up our medical school. So that's what we're going to be talking about today, is one of the ways that we're trying to be as community focused, and I like to say community embedded, even that's an odd word, as possible, is with this community advisory board. So I was going to give a little background about the new school. We just started our first medical students about 4 weeks ago, so they're brand new. But our vision, given the problems in East Texas, I'll talk about in a minute, was that the school had to really stay completely focused on that, improving the quality of life and reducing health disparities in our rural region, right? We want to train diverse, culturally competent physician leaders who understand the region and actually come from the region. I can talk about that in a minute. Who are going to work cooperatively with interprofessional teams. I think that's a really critical part of the vision, is that all of our students need to be engaged with people like you to actually make a difference, right? If we just train doctors who go and hang a shingle somewhere and do their medical thing, it's not going to actually change the community and change access to care and change fundamental outcomes. You look at, we all know the things that actually affect someone's outcomes in life, 80–90% of that is not medical or medicine, right? It's access to food, it's stable housing, it's all these things. So our students have to be expert in that and partnering with their communities to develop innovative value-based healthcare systems, provide great care, and develop novel treatments, right? None of that can happen without people like you working with our school. So that's why we put at the end, partnering with the community. That's part of our fundamental vision. And that's our mission. I don't know if you people have seen, if you guys have seen mission statements very often from medical schools. There's really 3 parts to them, right? It's provide clinical care, do research, and last is education. Even though it's a school, that should be first in most of them, I would say. But we have community engagement as the first mission in what we're doing. And I think sometimes our faculty get a little annoyed at me because no matter what they do, I have this research project, I challenge them, how can that involve the community and benefit the community right now, instead of just doing the research and publishing it and not really being a part of it. So that community engagement being the #1 thing in our mission is truly fundamental to what we're doing. So I like to say the School of Medicine is East Texas, and everything we do will be in partnership with our communities. Whether we do research to educate our students to reduce health disparities, research to address those health disparities, clinical access to top quality healthcare for the entire community, but we have to understand the community and be a part of it to be able to do that, right? So these are our values. Perks is the little mnemonic that we use to remember these. I talk about them a lot, but perseverance, excellence, respect, but the perseverance, community, and service, right? I bet everyone in this room knows a lot about the perseverance it takes to address the incredibly difficult problems you're trying to work through, right? And so I put that first as our value because I think that is just critical to be able to do what we're doing. And then community, a feeling of fellowship with both within the school and across the community, and service, right? We want our students to be transformational, service-oriented leaders who want to really change things in East Texas. So a little background on the school, just because we're brand new and we're excited about it. And it's pretty cool in East Texas to have this happening. That we had actually it was over 5,000 when we finished applications for our first class of 40 students. So pretty cool, amazing people applying. 2,034 completed applications, interviewed a few hundred, and then we matched our 40 students. And what's different about what we're trying to do is that we are completely focused on getting students from our region to be medical students in our region. The vision of our school is to be transformational and improving things in East Texas. It's not going to do me any good to bring a bunch of kids from outside Texas or Dallas or wherever who just leave after they get their MD, right? That's not going to do anything for the community. And there's been systematic exclusion of the actual students from East Texas from medical schools because of socioeconomic status differences and all these things. They have not had the opportunity to become physicians, even though they're as eminently qualified as some of the more resource students from big cities and those kind of things. I always like to say, and you've probably heard this a lot, talent is universal, but opportunity is not. So we are here to provide that opportunity to the students of East Texas to be able to become doctors in their home region. So this data is a little complex, but on our admissions here on the left side, we have 4 things that we look at in evaluating students for admission. The top row is the GTI, which is the Geographic Ties Index. It's basically your depth of connection to East Texas. That's our first screening criteria. You get points for being born in East Texas, or your parents were from there, you went to high school there, different levels of connection. And so if you look across the students that did not get interviewed versus the ones that did, dramatically higher GTI, meaning they were from East Texas in some way. And then one of the criticisms I got, and I was a little maybe offended by it, was people were like, well, if you just get kids from East Texas, you're not going to find talented students. They're not going to be as academically successful or able to complete. And that's a little offensive, because East Texas is an amazing region with 2 million people, and we've got amazing kids there. But if you look, their academic prep index, which is that line, was actually higher in the kids that we did interview from East Texas from the general pool who wasn't from East Texas. So incredibly academically qualified. And then we have a mission-centered index. So to evaluate how connected to their community was, how much service leadership they did, how much community service, all those things. And then the last thing is this thing called a CASPER. That's a weird word, but it's what's called a situational judgment test. And it actually evaluates how empathic, how humanistic, how ethical the students are. So what I'm really proud of in our admissions is that academics is 1/4 of what we evaluate in our students. Let me ask you, I ask this in every group I go to. If you were looking for a doctor, you wanted or design the ideal physician for you and your family, what characteristics would you want? Someone who listens to you, right? Actually is not just looking at the computer and right, actually understands, and right? What else? Caring. They actually care that you do well, right? Being culturally aware, understanding you and the culture and everything, because what we just said, right? Most of your health outcome has to do with your economic situation, your family situation, all those kind of things. So absolutely. Right. Culturally competent, right? Anything else? Skilled. They got to know what they're doing, right? So you guys just hit it. That's why our admission system is like that. I've been in medical school admissions for decades. And for too long, the vast majority of what we evaluated was grades in MCAT, which is the test you take to get into med school. There was not a big focus on everything you guys just said. So unfortunately, I think for a lot of years, we've produced a lot of physicians who are very, very smart, but maybe not with the bedside manner or the understanding of the community they're trying to serve. We're trying to change that. We're trying to get kids from the area who have those skills, who are committed to the community, and also academically talented. And I can tell you, and people were worried, well, what if you admit too many students or GPA is not high enough? Our average GPA of our admitted students was over 3.9. So not only do they have these incredible other characteristics, they're amazingly academically talented. And this is where our students came from for our first class. So the blue area, the blue region are the counties of East Texas that we focus on. And you can see that 32 out of the 40 actually born and raised in East Texas. The other 8 from these other areas had grandparents or parents or some kind of deep connection to East Texas. So it was very, very cool. And it's amazing hearing their stories, how they've always wanted to serve their community, the opportunity to actually go to medical school in rural East Texas. It's going to be transformational for them, for their families, and for the region, hopefully. So the next steps, we built a med school. We're going to train students who hopefully are very committed to the community and from there, but we need to be able to do the next step also where they do their residency. So you're probably aware after medical school, you have to do further training to specialize in pediatrics like what I did, or OBGYN or family. So we're providing that also. So we're dramatically expanding residencies in East Texas. About 4 years ago, we had 3 programs. Next year, we'll be up to over 20. And the metric in Texas is you want to have 1.1 residency slots per student slot. And we have 180 residents and 40 students. So we're going to have amazing opportunities for the students to train in their communities. This is just a short list of some of the ones that are coming online now. And we're actually embedding the residency programs in the smaller communities, not just having them in Tyler. What's funny, when I moved to East Texas and I moved to Tyler, I was like, hey, I'm moving to a small town. This is going to be super fun and everything. In East Texas, Tyler's the big city. Like it's the big city, right?
Yes.
It's amazing. And so when I go to the smaller communities, they're, oh, you're from the big city. Why are you going to care about us? I'm like, oh, a very different paradigm from what I've been used to. But so we're trying to build programs also in the smaller communities. This is some of the just growth. This year we have 180 from 147. So rapid GME growth. And then one of the big things, Carol and I have worked really hard on is establishing these early connections to as many community organizations like the ones you guys work with as possible. So we're directly participating with FQHCs, with community organizations, with other health systems, food banks, all these kind of things. Our students have a community service requirement. So trying to have a connection on every possible level for the students within the community. So again, this is the region that we cover. It's a 42 county region, encompasses the DSHS regions 4 and 5 north and 7 counties. And so we use this for all of our recruitment, clinical placements, and again, the goal focusing on the region to make a difference. So just very quickly, what are we trying to address? And you guys are probably aware of a lot of these types of challenges. We have really bad health outcomes in East Texas, huge shortage of physicians, especially in the smaller towns. And so we need more and better access to healthcare, right? That's how we're going to try and change things. If East Texas, so this is kind of a map of East Texas. The colors, dark brown is very, very bad health outcomes, and light blue is good outcomes. And if you look at our region, you have very, very bad health outcomes in almost every single county. And if we made that region its own state, which you could do, it's like bigger than West Virginia, the health outcomes would be between 47th and 51st in the country in almost every single one. So a huge amount of work to do. And you look at one of the reasons is the shortage of primary care. This is a map, and this speaks to all of Texas, actually. Dark blue means the entire county is a shortage area for primary care physicians, and light blue is part of the county. And if you look at that map, it's kind of the whole state. Right. So not just us in East Texas, but everyone has a lot of work to do to fill these gaps in primary care. And then access and coverage issues, you look at just insured populations, you look at the percentages of people on Medicaid and CHIP, East Texas, very, very high, right? So access to care is very, very difficult for our population. And just to use an example of pediatrics, because I'm a pediatrician, so I care about the children. In East Texas, there are so few pediatricians and so few resources for pediatric care. It's resulting in really, really scary outcomes. If you look here, we just did a study across all of East Texas on pediatric health outcomes. And if you look in Northeast Texas, the pediatric mortality in every age group is almost 3 times what it is in the rest of the US and much higher than Texas. That's unacceptable, right? We need to do something. We need to work with the community to make that difference. And then, I mean, you look at some of the social issues, Northeast Texas, the teen birth rate is also almost 3 times what it is in the rest of the US. A lot of work to do with the community. And it's really hard to get there. For patients in East Texas, over 60% of these patients have to drive 80 miles to receive basic pediatric care or subspecialty care. I mean, talk about how that would limit the number of times you actually go to your appointments or get care or any of that stuff. So I think that's a big contributor to why the health outcomes are poor. And on the right there, this is the number of beds for pediatric patients in Northeast Texas compared to statewide. And if you look there, we have 0 beds if your kid gets very sick. And the average time to get your kid, if your kid got hit by a car, had a heart problem, had sepsis, the average time to get to the correct care from Northeast Texas is 15 hours. How would that be being a parent and your kid's critically ill, waiting 15 hours to get to care? That's not okay. And it takes that long because you try to find a bed, you got to transport them, do all that stuff. So we're trying to have a true paradigm shift in academic medicine. Instead of having that ivory tower model where you're just doing your own thing, we want to be as embedded in the community as possible. And Dr. Morales is going to talk about the new way we're going to do that with a community advisory board that both takes input from the community, are we doing the right things, but also provides a connection point among different previously somewhat siloed organizations that are doing great work, but haven't really connected to each other. And then also provides resources to those organizations. Like, how can we as a medical school really value add right now to your organizations, provide resources, provide talent, provide faculty, all those different things. So with that, I'll turn it over to you.
So our inspiration is really coming from leadership at the AAMC. President and CEO Scorton talks about and has published about this idea about a new contract. And the traditional model, if you look at here, is really the focus has been research, clinical care, and medical education. But if you look back at our mission, that was one of the previous slides, we listed community engagement first. And that's a shift. That's a shift in thinking. It's a shift in strategy. And so for us, when we think about how we formulate that strategy, we're really stepping into this idea of a new social contract. And so for us, that means that we're looking at how we connect with community. How do you connect the lines? How do you dot those lines? And how do you formalize those relationships, right? Beyond just the clinical care that's provided, beyond just the research and medical education that we offer to the stakeholders that are a part of our community. And the reason behind this shift in thinking is that those traditional approaches we're being advised that it's no longer enough. There are still social determinants of health that impact how we reach out to these stakeholders, and those have to be part of the conversation. And so one of the ideas here that we have to do more to affect change is that we have to recognize that integral to these conversations is the level set. The community is a stakeholder. And there's a stakeholder we have to sit at the table. There's a stakeholder that we have to engage in dialogue with. We have to understand where the gaps are so that we can collectively move the needle, right? And so that means we have to work in partnership with each other. Integral to that dynamic, and I don't list it here, is a power dynamic, right? And you have to have conversations around the power. The way I sit at the table is going to be different than someone else, right, from our community, potentially. And if there is that power differential, it has to be part of the conversation, right? Because for them to contribute, you have to acknowledge that I sit at the table with power and privilege, right? So we basically, when you do the level set, you then create opportunities for improvement. And one of the ways that happens, and it's one of the models, when we talked about formalizing our community advisory board, I did a lot of research because one of the things we talked about, I asked Dean Wells, I said, have you done that before? He goes, nope. I go, have I done it? No. So we did a deep dive into all the best practices, and there's a lot of models out there, but we stumbled onto this one, the National Academy of Medicine. It's relatively new, came out in 2022. And really what I love about this model is that at the core, at the core of our mission is community engagement. And it basically says the principles that guide community engagement. And what I love about this model is that you take what you use what is beneficial to your approach. So this is just a suggested model. So for us, it meant looking at how then do we make it, someone talked about making it culturally centered, right? How do we then create bi-directional information flow and sharing? Integral to this core principle is establishing trust. There are other core principles there that you can also look at. But then you also see these petals, these going left to right, these are called domains. And so when you put into practice community engagement, utilizing the core principles, then you look at these indicators here. So how do you know that you're strengthening partnerships and alliances? Well, you could be looking at creating opportunities as you're doing this outreach. You could be making sure that you create the mechanisms so those relationships are sustained. You could be developing trust. You could be sharing power, right? Whatever strategies work for you in terms of your own development of a community advisory board, that will then allow you to basically, once you're sharing information, sharing power, to expand the knowledge, right? Because community stakeholders have acquired a level of wisdom in terms of their experience, and tapping into that knowledge is fundamentally important for us to co-create potentially transformational solutions. So if you expand the knowledge and you create potential new strategies, right, that can then lead you to improving health outcomes, policies, practices, what have you. That can also then ultimately guide you to the opportunity to create thriving communities. And all of these are essentially leading you to this process of transforming systems of health through drivers of change and health. I'm going to move to the next slide, which will basically explain this a little bit further. Let's see. No. Let's go back. Thank you. You got it? And the internet's a little slow, we've been advised.
When community engagement is present, when the core
engagement. I'm also founder and executive director of the Health Education Council, a private, nonprofit, community-based organization, which for over 30 years has been devoted to reducing health inequities amongst diverse, historically excluded communities in our region. I come to
conceptual model reflects what we know community engagement to be.
21,
Turn the virtual microphone over to Cincy Hernandez-Cancio.
Okay.
Good morning, everybody. It's such a pleasure to be here with you today. My name is Cincy Hernandez-Cancio, and my pronouns are she, her, and ella, and
they're designed to serve. Starting with the first pedal or propeller, under strengthened partnerships and alliances, the indicators there highlight the benefits of strong relationships, and those indicators include diversity and inclusivity, partnerships and opportunities, trust, shared power, and structural supports for community engagement. Under the next pedal, you see expanded knowledge. And here we see the creation of new insights and resources and stories and evidence. Indicators here include new curricula, strategies, and tools, bi-directional learning, and community-ready information. On the third pedal, you see improved health and healthcare programs and policies. We identified indicators that allow for developing solutions that are fit to purpose, in that they are embraced and championed by those that they're designed to serve. And the indicators here are community-aligned solutions, actionable, implemented, and recognized solutions, and sustainable solutions. And then on the fourth pedal, you see thriving communities. Here we identified indicators for physical and mental health, community capacity and connectivity, community power and resiliency, and life quality and well-being. Next slide. When community engagement is present, when the core principles are embedded into the process of community engagement, and there is movement both within and across these domains and indicators, we ultimately facilitate action towards health equity through transformed systems for health. As I mentioned earlier, the systems for health are inclusive of all systems that impact and influence health. We also know that there are several contextual factors that you see around the model that influence our work on community engagement. There are the drivers of health and the social determinants of health. There are the drivers of change in health, which are the key levers that influence stakeholder action and include things from grassroots organizing to regulations to financial incentives. And then there are the relevant social, political, racial, economic, historical, and environmental contexts that also underpins all community engagement efforts. Community engagement exists within all of these structural systems. And the organizing committee ultimately believes that true meaningful community engagement can shift not only outcomes in the model, not only health equity and systems for health, but true meaningful engagement also has the opportunity to shift these contextual factors as well. Earlier, the systems for health are inclusive of all systems that impact and influence health. We also know that there are influence our work on community engagement. There are the drivers of health and the social determinants of health. There are the drivers.
Okay. So we are going to switch to the next slide and go into a group exercise. So you have a little bit of insight about the model that we utilize to develop our community advisory board. So our goal here is to have you deconstruct that model, right? We know that models are just an approach, a new way of thinking around how to craft strategies for solutions or challenges that exist in our work. So our idea is for you to take a critical lens to this model and see how it might be adaptable to the work that you do. And so I'm going to have you break into small groups. Let me see. So we have about 16 here. So I'm thinking around groups, maybe four groups of 4. You're going to have ideally around 20 minutes to have a conversation about what is useful in that model and what you could apply. And take a look at it critically, because there is no one size fits all. And so then if you could also select a facilitator from your group that will also report out to the larger groups, and we can figure out how and what ways you could utilize this model in your work. So we're going to go ahead and feel free to utilize the room as you feel free. So go ahead and break into groups of 4, and we'll have you share in about 20 minutes. Okay.
And then, sorry, just for the room, one quick announcement. When we do bring it back from the small groups and you are, your facilitator is presenting, we'll have our lovely moderator run this mic over to you just so our online participants can hear you as well. That's the only way they can hear like what's going on in the room. So thank you.
Okay, everyone, we're going to come back together as a large group. And I hope everyone has had an opportunity to select someone to present to the group. So we'll go ahead and have our moderator just feel free to start at a table, and we'll have someone just share what was beneficial with the ACE model that we talked about earlier. Who would like to start first? Okay, great.
Ask what was beneficial.
Mhm.
So immediately we thought of system of care. We are like, this is exactly system of care, but just for the medical model. So that was kind of an easy one for us to understand. Do you want me to report out on anything else? Or
Yes, anything you feel comfortable sharing from your group?
Sure. So we thought about this model and we're thinking of those, people who are in medical school at this point and looking at this, including in participation in community events. So everyone in this room does some sort of children's community event, whether it's tabling or Children's Mental Health Awareness Day, having those students come and kind of understanding, hey, folks are going through this and they're here, just kind of having that exposure. And then we were kind of thinking about with this model and with, medical students, where are these students coming from in relation to mental health? So what are they coming into this? Do they have an understanding? Do they not have an understanding? Do they have a lived experience? And I think, thinking outside of the questions that you asked about this, having all of these students come from East Texas specifically, and having that on top of there, just growing the understanding of what are the needs on top of, the medical school needs. Was there anything else?
I just remembered, we also talked about the importance of peer support for the trust factor.
Yes.
That, as you're going into community and you're working with community, and if this is a new idea, to find people that can go, yes, this is my trusted friend.
Yes.
And move it forward that way.
Yes. Do we have another group?
One follow-up.
Oh, sure.
I love those ideas. And we are trying to do that with our students to have them. There's a actually dedicated behavioral health curriculum thread that they all undergo. And again, you're right, being from the region is critical. Just to make a point also, we're very intentional about this. Dr. Morales actually grew up in Tyler. And so for her to come back and be our associate dean of community engagement, I think speaks to what you're talking about, somebody who really gets the community. And
Another group?
Would you guys like to share? Anybody?
Well, we were still just trying to get an idea of what everybody's role was and how we can kind of combine it together from our strength and weaknesses within our own organization. So we didn't actually get as far as others, but we actually got as far as our working with workforce, how we come in direct contact with the families, not only for childcare, but then we're addressing that they're having other needs, homelessness, they're running out of food, and connecting them, and where he explained what their role was. So that's kind of where we was kind of tying into one another, but we didn't get that far.
It actually makes I love that point you just made, because it's actually one of the key things that happens with our community advisory board in the med school. We got all of our community organizations in a room like this, and conversations like you just described happen, and people are like, I had no idea you were doing that. And it made this incredible connection there. Hopefully leveraging the resources of medical school with that synergy, it's going to make those community organizations way more effective. And it's just crazy that had never happened before. Like in a small town like Tyler, even they didn't know that they were operating in the same space and had similar goals, and how can we work together? So that's your great demonstration of what's already happened at our community advisory board. And then the other question I really want people to think about is, you have medical schools in your area that have really impressive resources at their disposal. And so how can you work with them to leverage those resources to get things done that you need done, right? Really lean into that relationship.
Most definitely. Yeah. We'll do one more table and then we'll go back to the next part of the presentation.
We can go. We really talked about community connection also. I think we all like focused on like our different silos, but she was really talking about how behavioral health is embedded in like the pediatric offices, and just how maybe more could be embedded in that office. So she was saying like families, when they're already there for, child visits, like what else can be there? I think someone was saying like getting access to medication, like some families don't, because it's hard to, get on another waiting list to see another provider. But just really like how maybe making like the pediatric office, like this hub where like connects families more. So we thought that could be exciting.
Yeah.
Kind of like a one-stop shop.
Yes. Yeah. Oh, feel free. Yes.
You want me to go? Okay. All right. So our group talked about having our hospitals that are in some of our rural communities. Some of them are not connected to a medical school. And so our systems are kind of falling through the cracks as far as getting those community connectedness. So that was kind of what we talked about.
Okay, thank you. So then our next phase is some of what you've already discussed and shared, is looking at connecting this idea of this model to our community advisory board. And so then what we've done is essentially create a purpose. And essentially it represents leaders throughout our East Texas region. Various sectors are represented, the nonprofit, for-profit, and educational organizations. And essentially their goal is to work in partnership with us and serve in an advisory role and provide advice and recommendations that really help us to align the resources between our campus and the community, and create shared knowledge and establish a collaborative process. It's also really the information, I can't stress that enough, and creating feedback loops internal to that process so that we are building a level setting kind of a base of knowledge about who's doing what. You talked about that earlier. And then creating ideas, opportunities for novel ideas and approaches that'll guide our work at the School of Medicine and clarify how we can add value to the East Texas community. And then considering those contexts that are part of that base model and how they perpetuated health equities within our region, creating some knowledge and awareness around that. And then co-constructing transformational projects, programs, and services, research with a research focus, some of them, to reduce disparities in health outcomes and improving the quality of life and health in East Texas. So that's our purpose. This is what our composition looks like. And so we have folks who are boots on the ground, but we also have embedded in there the social determinants of health, right? Food security. So East Texas Food Bank is a critical player in that conversation. East Texas Council of Governments, they have a transportation arm. And so we know transportation is another factor in terms of how people access health. So it's an interesting kind of cross collaboration between where we look at the resources that we have in play, and then we get those players at a table. Of course, we have our own stakeholders as well at the university. So when we first gathered, it's like, okay, so let's introduce ourselves to each other, and let's also figure out what are the needs. What are they identifying as the top 5 health needs? I kind of already knew mental health would be there because I kept hearing as I was reaching out to folks and trying to get them to consider joining our board. And so mental health is the first one at the top of our list. You'll see here rural access, health across the lifespan, qualified medical professionals, we already know that that's a challenge. And then lifestyle management. So those are the top 5 health needs. So our core efforts have really been to really get to those stakeholders, to forge those relationships so that we build trust and that we are co-creating an agenda. And you see that listed with mental health, which we are beginning to evolve some strategies around, getting a sense of where the data guides us. What does the evidence tell us where the most compelling needs are in our region? And then looking at ways that we align resources around those needs. So this is a representative example of how this is evolving. So this is the School of Medicine Community Advisory Board. And those are some of the stakeholders. We then looked at trying to find, well, where's the data? That was a challenge in amongst itself. So we found a Region 4 and Region 5 Prevention Resource Center data coordinators. And so we looked at then, they crank out a report, an annual report that looks at the health needs in our regions, but we wanted more. So I asked them to send us the indicator list of those things we could assess, do a little bit of a deeper dive. We had a small group internally that said, let's faculty and staff, most of you had a behavioral health focus, say, we need more here. There's a gap here. So we sent that list back to them. And then they presented to our community advisory board where the needs were. And it basically told us Marion County. Marion County has no physician in the county. They have a licensed nurse practitioner and his wife is a pediatric nurse practitioner, right? There is an ambulance that straddles the county line, right, between a neighboring county. A doctor visits once a month, right? And so we thought, well, then how then do we then leverage our resources to kind of work with Marion County? As luck would have it, they already had a mental health resource coalition that was already going. As luck would have it, we had UT stakeholders who were already partnering. So they just had in June their first fair, health fair. And so these are some of the stakeholders who were present. And it really is a collaboration between the university, our School of Medicine, other colleges were also present, other schools were also present, but also the community itself was represented. And we built that fair. And it was probably, it was a wonderful opportunity for everyone to kind of coalesce the resources so that we could share with the community what service providers were available. And it was interesting to me as I walked the table that morning, it was a Saturday morning, I myself, someone from East Texas, found an array of organizations I wasn't even familiar with. And some of the attendees, I heard conversations, sidebar conversations, over, I was eavesdropping, listening to them, talk, oh, I didn't know you were here. I didn't know your service reached my community. I thought you were in this other county. Right? So a lot of level setting in terms of information sharing. And so then going back to our campus, we thought, well, let's see if we can create another opportunity. So one of the ongoing ideas, it's still in development, is this idea of a psychology practicum. We have on the main campus, College of Education and Psychology. And so we are trying to partner with our own resources, the School of Medicine, to create an opportunity where we could potentially then get students who have to complete a practicum to potentially do it in Marion County. So this idea is evolving, but this is the way you can utilize the model. And so this is going to take us to our next group exercise. I want you and your small group, you can go back to your small groups. We're going to probably condense it because of time. Look at if you could create something like a community advisory board, who would be part of your group? How would you evolve that strategy, right? This is going to be we have half an hour left, a smaller exercise, and I'm going to probably say, let's do it in 5. I challenge us to do it in 5. And I'm just going to ask 1 or 2 people to come back and share some ideas, okay? And I'm going to go back. Ooh, I'm going to have to. There's yeah. Yeah. I think it's gonna. I don't know that we're gonna. Well, no. I can go through this really fast because I want Q&A. It's 11:45, we have half an hour. I'll do mine in 10 minutes. I'm gonna go through and that'll give us 15 minutes. The intersectional piece, I'll do it in 10 and that'll give us 15. Okay. It always goes by fast. Busy. I'm sorry. Yeah, I get it. Yes. Yeah. Yeah. But I think I've had a little bit, I've been invited to a lot of more conservative pieces as well. I've been going. Oh, yeah. Because, Oh, yeah. No. And in Marion County last meeting, Will, who's the city alderman, he said, Carolyn, I want you to close this out in prayer. I said, well, I'm not Christian. Oh, yeah. So they look stunned and he goes, well, what are you? Yeah. So when he asked me, I was like, of course, I'm like, I said, well, I'm Buddhist. And he goes, oh, and he didn't know what to think. He goes, well, and then he pivoted to one of the other pastors. Yeah. I don't, but I didn't expect it. Yeah. Because I don't think my prayer would have been received, which is why I was trying. And he didn't want, he referenced to the other pastor, he defaulted very quickly. So I thought, I find it, and I think it's part of our culture and we just have to respect it. That's just part of who it is. Oh, yeah. Okay, I'm gonna call them back. Okay, everyone. So I am, in the interest of time, going to ask that we get one or two individuals just to briefly report out, what would be beneficial to you in the development of your own community advisory board.
Okay, so we were thinking about first including system of care. If there's a system of care in your area, having them, having the school system, that would be a good place to be because that could be a hub for mental health services, not necessarily a hub for the school providing services, but just having the, feedback from the school system. We were talking about faith-based communities. I know you had that on your list. Natural leaders. I gave an example of, I was thinking rural Texas, if there's a restaurant that's been around for a long time, having them come to the table. They might not fully understand, what's going on, but that's a big voice. And if they're a part of it, I think a lot of community members will come behind that. And I think that was it.
I think that's like spot on. Going to the community, unofficial community hubs and points and the leaders. Everyone knows where, people congregate. And that's also those critical, you understand the nuances of the culture of your community and you pivot to those resources because those are information gathering places. And so you can share and disseminate what you're doing and how you're doing it, and then invite them to engage in that process. One more.
Okay, so we had a couple, medical professionals such as physicians, dentists, children's hospitals, CPS, school district, community partners, parents, of course, local government representatives such as city councils, juvenile correctional officers, Boys and Girls Club, and I added early intervention. So yeah.
So as you think about forming these groups, right? And you can take that model and apply it in whatever way you think will be useful to you. One of the strategies that I wanted kind of to present, and in the interest of time, I'm kind of go through this a little quickly, but I'm always available if you have any questions, happy to have a conversation in more detail. So an intersectional analysis looks at how these disparate parts connect. So that we're all on the same page, intersectionality here. One of my favorite scholars, Hankivsky, is moving beyond examining individual factors such as biology, socioeconomic status, what have you, and focusing on the relationships and interactions between these factors and across multiple levels of society to determine how health is shaped across population groups and geographical context, right? So I'm going to skip this video just because in the interest of time, but I'm going to move us here. So when you look about intersectionality and connecting it to health, you're having to really think about individual identity, right? So I am Peruvian American, I'm also Mexican American, right? But the group affiliation would cluster me in Hispanic, right? Social determinants of health, first generation, my parents are migrant workers. Social systems, the access to education, right? Socioeconomic status those are variables. And then what did that produce in terms of health outcomes? Comorbidities, especially with my mother, genetics, diabetes, heart disease, right? So all of these factors connect at the very center. So when you keep them separate, it's like a puzzle piece. You can miss the big picture. So in my mind, rather than looking at these as an additive approach or they coexist separately, they're connected. And that's really the fundamental shift when I think about intersectionality and applying it to health. And so this is the model I wanted to present to you. So you'll see that these first four here are all connected: individual identity, group affiliation, social determinants of health, and healthcare systems. So identity we talked about. We also talked about comorbidities and genetics. But, it may or may not, my individual identities may or may not align with the group affiliation, right? The term Hispanic is not something I prefer to use, but, when I have to check off a box, right? And some alignments may be stronger than others. Well, when I'm with my family in Peru, they default to American, but I default to my Peruvian side, right? And it can change, depending on the context or where you're at. And then linking it to social determinants of health, you're all well aware of the social determinants of health. You see that every day, boots on the ground with the work that you do. And so then how do all of these variables here impact the quality of care that people receive, right? You have to take into consideration that people may or may not be able to equally access because of finances, health insurance, and then what options does that provide to them? The workforce composition, we know that there's shortages. So then how does that impact your ability to access health resources when you need it? We also know that there's varying sorts of delivery in terms of how people are treated once they get to those resources. And then, of course, some hospitals, some have more resources, technological resources than others. And then transportation, accessing care. So how did all of these connect to this healthcare system? But it shifts at the end of the day, the outcomes, right? Because when you look at them in isolation, you can miss the forest for the trees, right? Because the benefits of intersectionality are it basically disrupts these kind of assumptions that you're just one thing, right? You're a multiplicity of things. That's how life has shaped you. And that these strategies that we normally look at, well, this patient is this, and we look at it in the single frame access. It's called single access orientation. We have to look at it as a collective. I'm more than just one thing, as are you, as are the patients that we treat. You have to look at how these things overlap, how they're shaped by social determinants of health and the social systems at play, such as academic medicine centers, health centers. You have to look at basically, then it gives you some insight as to who is left behind and why. And then you look at this intersectional approach as a multi-level analysis, right? Beyond just one dynamic, beyond just one factor. You're looking at how they are connected. And then really looking at the end goal, it gives us the opportunity, when this level of analysis is employed, the opportunity to really level set the goal of health equity for our most vulnerable and marginalized populations. Okay, so I know that we are at 11:25. We really at this point wanted to open it up the conversation so we can really give you an opportunity to ask some questions about the ideas that we've presented today and how we're evolving the community engagement focus at the School of Medicine at the University of Texas at Tyler. So we are inviting you now to kind of ask any questions that you might have.
So with all the work that y'all have been doing, do you have like a physical group that meets periodically, and what does that look like?
We do have a community advisory board. It is at last number, we have around 58 different organizations that are represented. And they cut across, as I mentioned, the for-profit, nonprofit sector, business as well. And so we meet every 2 months. And so we are actively focusing on mental health right now. And we have a new leader who's just come on board, Dr. Cheryl McCollum-Smith, who's really will help shape our vision around how we strategize around mental health. And so she is now a member, and she will help guide us as we develop those very specific strategies so that we are reaching our community stakeholders.
I have a follow-up to what you
Sure.
just said. So you have the individual coming in talking about mental health. Are you looking at mental health, because you're in East Texas, from that lens, or are you, thinking broadly when you're educating the up and coming physicians? What does that kind of look like?
So everything we do, we're trying to look at from the lens of our region, because that's our whole reason for being, right? So the behavioral health curriculum that we're designing, and actually our entire curriculum, even if you think about when we're educating students on cardiovascular health, where the cases that they learn through and everything are actual East Texas based problems and cases and those things, because it's a different context than urban Dallas, right? Rural East Texas is different, delivery system is different, everything. So everything we're trying to do, we are trying to do through the lens of East Texas. And that's why this effort is so critical to what we're doing, right? Because we actually present our curriculum to our community advisory board. Like, this is what we're going to do. And I want them to say, that's not right, right? You need to focus in this way. So to get that actual integrated feedback from our community that we're doing the right thing to serve that community, and vice versa. The other big thing is behavioral health. How can we value add? So one of our big efforts right now is providing our faculty, providing our statisticians, our data crunching ability to produce a focused report on the behavioral health outcomes for the region that then all those organizations can use to apply for grants or make presentations to community leaders, all those things, right? So that's an actual tangible thing that we as a med school can provide to the community organizations. They may not have had the resources to do. So everything we do, we try and look at the lens of how does it actually help East Texas.
Any other questions?
So recognizing that East Texas is not the only rural community across the state, but I know, y'all spoke earlier to collaborating with medical schools. And I think about some of the areas that within my current agency and previous roles that we've served, like some of the rural areas out in the hill country, like San Saba and Llano and Horseshoe Bay, and then communities like Taylor, where transportation is a barrier for those patients. So no, they can't get to Austin or Round Rock or Georgetown, where a lot of the healthcare is. And what recommendations or suggestions, ideas do y'all have for those communities that also are communities that it's really hard for the patients to trust those outside of their community, but also don't have the resources in their community? Like, are there any recommendations for when we're collaborating with med schools and such for how to approach those communities and kind of meet them with their needs?
Yes.
I think getting a champion for those efforts is critical, right? So having Dr. Morales kind of running this effort at our school is the fundamental thing. So I think if you had needs like that in rural communities, and say is the closest medical school, I think engaging with them and trying to find out who in that organization is passionate about this, right? I guarantee you they have people who do that, and then trying to push them and trying to get the school that's nearest you to start efforts. Most of them have some kind of community engaged effort. They may not know that Taylor needs these particular things, right? So that's the other part of this board and trying to get an effort like this started. That's educational for the leadership of the medical school, right? So I think the first thing is trying to reach out and find out who in the medical school is interested in these kind of community efforts, and then starting that work with them, right? But it's not going to happen if you don't have somebody in the school who's like a super user, a champion of those kind of things, right?
I think it's important that you develop those relationships and recognize that there are some barriers that are going to be incredibly difficult to overcome. So going to them, and that's part of what our Marion County Health Fair has done. There's a power differential, resources, you have to go to them and then engage them in dialogue about those solutions.
And it's been really, already inspiring to me when we go out to the organizations, and it's kind of powerful. They're kind of, I don't know, very engaged and happy that we're actually doing that. It's not even that hard of a thing, right? Just go out there and engage in that conversation, but it really means a lot. And once you start that relationship, it's amazing what can open up and the kinds of synergy that can happen.
So what is your community advisory board's name? Do y'all have a name for it, or is it just CAB? Okay. Well, the reason I ask is in my former community, I was in McLennan County, and we serve 6 counties around us. Our community advisory board is called OCOF, Our Community, Our Future. I don't know if you've heard of that. And we had probably about the same amount of people in community members, and we tried to make sure that we also included a family voice in that, so that there were, not just community members, but the family voice was part of it. It was a huge piece, and I got to be a part of that group, and it was really, really cool. So I think it was very similar to what you guys are doing, and I really like the idea behind it.
Yeah, I love that. And we do want to include families and patients, so you get that actual on the ground experience of, are we doing the right things for the community, right? And in what way can we expand it?
How is the tracking done when a family need is, a need is addressed, going from the physician then into the community? How is that tracking done?
That's a good question. I imagine we still have to work on comprehensive tracking, right? Because we still have multiple community organizations doing different things and we're trying to link them. But I don't think we have like this patient needed this resource in their doctor's office and how did it actually come out? But that would be a great next step, right? Making sure we are trying to track the overall efforts of community engagement that are happening across the community and within the med school where there's actually a nice online platform. And this is another thing we notice, there's siloing even within universities, right? You might have this department doing this effort and they have no idea this is. So we're engaging with this resource called Collaboratory, and it shows a nice sort of dashboarding of all the different community engagement efforts happening across the university. So I think that combined with trying to link the community efforts together might lead to better efforts like tracking outcomes. And
in order to show an impact, which is incredibly important to this work, you have to be measuring, right? Now you can go to your neighbor and say, we're doing this great project, but we know that in terms of accessing additional future resources, sharing knowledge about best practice of what's working and how it's moving the needle, you have to be documenting and recording the efforts so that you can illustrate that to future stakeholders and current ones who may not trust that, here we go again. They're the new group, new players come on board and they're gonna try to work with us on this. But when you create new opportunities to track what you're doing, then it goes back to that model, that bi-directional information flow. It helps support, it level sets that power dynamic, and it helps build the trust. And even further enhances those relationships that you're really trying to nurture as you're moving the needle.
How do you guys keep your board members engaged, like not just attending the meetings? I think something that my agency has struggled with our governance board is that at times we have people coming to the meetings, but there's no input, there's no feedback. So I guess we're kind of stuck at like, how can we get them re-engaged, or how do you get the buy-in?
It's been really important that we empower them. Right? So it's not the School of Medicine's meeting, it's our meeting, right? As they're coming up with the agenda, it's collectively being developed. We invite people to participate. We have a suggestions, we have an idea. I was in the most recent CAB meeting and I had an idea, put a lot of thought into it, presented it, and they were like, it's not going to work. It won't work here in East Texas. I had individuals come out to me after 3 saying, I hope you didn't take, I go, no, I wasn't offended at all by that, because I feel for me, it's a compliment that you feel comfortable saying in front of everybody, good idea, but it won't work here, right? Because that's the kind of invitation to feel comfortable speaking that to me is the biggest compliment. The other thing that we know is that after our meetings, and I wasn't sure if it was just the first meeting, people stick around. And they're sticking around for at least half an hour, 45 minutes, sometimes an hour after our meetings end. And they're developing relationships. And they're even beginning to collaborate across organizations, because when they realize there's a gap here, but I have resources, let's connect the dots, right? And that you hope and pray happens. But when you create, I think, the dynamic where people feel empowered to co-create solutions, then you just have to sit back in that pocket and release it and allow it to kind of naturally evolve. And that's kind of the phase we're in. We're still adding new players. It's an informal community advisory board. I'm not going to sit here and take, who came and who didn't came, because when you can come to the meetings and contribute, that's all that we ask.
Well, I think a critical piece to that, and you're so right, I'm on a bunch of boards and mostly you just sit there, right, and you hear updates and nothing happens. You could be there or not, it doesn't matter, right? We want all of our members to understand that their input results in action, right? And so you're going to be engaged if you know your ideas, suggestions result in something happening, right? So we've already been really intentional about having value add solutions to things that people bring to the meeting. For example, we worked with the East Texas Human Needs Network to do a comprehensive community survey. our faculty, our residents, our students all participated and did like amazing work to make that robustly successful. We're doing a health status report on behavioral health that's going to be, again, provided to the members because of the suggestions that they made, right? So I think those really tangible value adds that we took action based on what you told us, as opposed to me just, or Dr. Morales just standing up there and saying, this is what the med school is doing. And that's a couple of other universities I've been at. That was the community advisory board, right? People would show up and you'd have somebody just say, hey, the med school's doing this, like, thanks for coming. Right.
Welcome. Thanks.
We have about 3 minutes. If you guys have any other questions, let us know. Anything? Nothing? All right. Well, I appreciate Dr. Willis and Dr. Morales. Thank you so much for being here and presenting on the community engagement and health equity. We really appreciate all of the information that you guys have presented today. Some housekeeping notes. Before the end of the session, I've got to tell you all about it. Are you ready? Scan the code. I put one on the inside of the door, and then I also put one on the outside of the door. If we need another one, I have more. Please make sure that you do this to receive your CEUs so that you can submit it on your tracking form at the end of the workshops. Lunch will begin after this session, so please take the time to meet other attendees, check out our exhibits in the atrium, and the next workshop sessions will begin at 1:15. So thank you guys for coming in. I appreciate all of you.
Okay. Thank you.